Hello. In chapter 9, we're discussing dissociative disorders. This disorder is characterized by disruption of or discontinuity in the normal integration of consciousness, memory, identity, emotion, perception, body representation, motor control, and other behaviors. So, dissociative experiences seem to be triggered by unexpected trauma or severe emotional threats. So, it's really important to understand what they can be triggered by and what can be the etiology of these issues, right? One of the biggest disorders we're going to discuss in here is in this section is dissociative identity disorder, formerly known as multiple personality disorder. So, several variables that are related to a person's vulnerability to dissociative disorders, and they are childhood trauma, suggestibility, and biological factors. So, key aspects of dissociative disorders. The key symptoms found in most dissociative disorders are amnesia, losing memory for one's identity or the loss of periods of time in the past, depersonalization, feeling detached from oneself or as an outside observer of oneself, derealization, since the objects in the world are strange, unreal, or have subtly changed dimensions, appearance, or location, identity confusion, being unsure of one's own identity or who one is, and identity alteration, behaving in the way that suggests one has assumed a new identity. So, culture and the dissociative disorders. Recognize the importance of difference in shaping the person's experience with assessing pathology associated with disassociation. So dissociative experiences like trance states, speaking in tongues, spiritual possession are widely accepted and practiced in many present-day cultures. So again, you want to make sure you know your client's culture, their religion, beliefs, or whatnot, and the tenets of that religious beliefs, because sometimes it can look as if they're disassociation or derealization or depersonalized or whatnot, but it can be a tenet of the faith. The assessment attends to the person's cultural identity, cultural psychosocial environment, and cultural aspects of the relationship between the individual and the practitioner. So, DID, as I just discussed, formerly known as multiple personality disorder, is considered the most severe of the social disorders because the most common and fundamental alterations include the presence of more than one discrete identity. Right? So here's the criteria. And remember, if you diagnose this with a vignette, you have to diagnose how the client meets each criteria using examples from the vignette. So presence of two or more distinct personality states, not better explained by imaginary playmates or fantasy play in children, involves an obvious discontinuity in the person's sense of self-accompany by alterations in affect, behavior, consciousness, memory, perception, cognition, and sensory motor function. And that's seen by others or people around them, right? The various personalities tend to be distinctive and dominate or control the behavior of the person. The person has trouble remembering everyday events, important personal information, or or even traumatic events in a way that is very difficult from ordinary forgetting. And the symptoms cause significant distress or impairment in social, occupational, or other areas of functioning. So next one we have dissociative amnesia. Here are the patterns of dissociative amnesia. So localized amnesia, inability to recall an event that occurred during a particular time. Selective amnesia can bring to mind patchy recollections of an event, but the other portions of time are forgotten. Generalized amnesia encompasses of all experiences during a person's entire lifetime. The person cannot remember anything from infancy to present. Continuous amnesia, inability to remember all events from a given time up to including the present time, while retaining memory prior to that given time. And systematized amnesia, losing memory pertaining to only to certain categories of information, such as information related to family or work. So here are the symptoms for dissociative amnesia. At least one episode where he or she is either partially or completely unable to retrieve important memories and personal information inconsistent with forgetting. It causes significant distress and interpersonal difficulties and cannot be attributed to the effects of alcohol or drugs or other neurological or general medical conditions. So dissociative amnesia with dissociative fugue, especially if involving unexpected travel away from home or work, and inability to recall the past, assuming a new identity, and inability to remember important personal details about the past. The stimulus for fugue state usually involves the individual leaving behind some kind of difficult or troubling situation that he or she finds intolerable. So it's far more common in movies and television programs than in a clinical practice, so we barely see this. Depersonalization and derealization disorders. Those with depersonalization and derealization disorders experience themselves or their surroundings as strange or unreal in some way. Experiences, depersonalization or derealization, are both. The depersonalization experience is highly subjective. The individual reports feeling detached from his or her body or more like an observer. Derealization, they might feel detached from their surroundings, right? So really, reality testing remains intact, but it causes significant distress. Also, remember that depersonalization and derealizations are also specifiers for PTSD. So when we compare this to the DSM-4, the criteria for dissociative identity disorder was expanded to DSM-5 to include possession from phenomena and functional neurological symptoms. In addition, transitions into identity may be observed by others, self-reported. Gaps in recall include not only trauma, but also understanding to everyday events. And dissociative fugue became a specifier in the DSM-5. And depersonalization disorder is now termed depersonalization / derealization disorder.